in 8 minutes or less, let's go through atherectomy and antirestenotic therapies. These are all my disclosures, some of which are germane to this, namely the DEF-LE trial, which I helped lead with a couple of colleagues. So some ground rules. What you've seen today thus far is really that the SFA landscape is fluid. Stenting would probably still be considered a predominant therapy, but a leave nothing behind strategy has really gained a lot of traction. And in this idea of leaving nothing behind and the complexities of the SFA that we normally see, vessel prep remains a critical component of what that leave nothing behind strategy entails. And what that vessel prep means is really debatable, and that's what this chat is supposed to describe. Any randomized trial that you see and have read and understand is unique. Any registry to that randomized trial is equally unique, and you can never draw distinctions or comparisons between the two, even though they got the same name. And that's critical to understand this. And alternative therapies, which is what we want to chat about, may or may not still be an important avenue to a leave nothing behind strategy. Professor Iida just went through the IMPACT data set. I just want to look at one very important thing. You saw the 4-year data on IMPACT, and what's critical on the IMPACT Global is that the predilatation that was mandated in the randomized trial was left to the operator's discretion. And because of that, one of the critical parts when it comes to long lesions, in the randomized trial, stenting was a minority of patients, about 10% or less. In the long lesion cohort, it was, in the in-stent restenosis, this is Marianne Brodman's paper, 14% were restented, and in the long lesion cohort, 50% were stented. So is this a DCB trial or is this a stent trial? That is debatable. Makari's paper that Sensei just showed you showed 25 centimeters. Here, predilatation was mandated to be at least 4 minutes. They had outcomes now with 17% stent rates at 71%, a really remarkable outcome for these long lesions. So in some way, vessel prep, whether it be simple balloon angioplasty or just kind of the drug-coated balloon, is going to be an important part and a segue as to why this works. And then Tony showed you the EXCITE trial. I just want you to see that the EXCITE trial, not belaboring the specifics of the trial, but the outcomes on EXCITE are on the lowest metric of TLR and primary patency. It's a coin flip as to whether or not it works. And that's because you already have a ramped-up stent design, and it's already got restenosis, but you were far better than, that's why it was stopped early, it was far better than angioplasty alone. That's why the FDA gave it its approval. But understand where you're starting from when it comes to a leave endoprosthetic behind, and we'll talk a little bit about patterns of restenosis. So, and if you looked at the line of identity, short of a diabetic, everybody was left of the line with the excimer laser approach, and this is why it got its approval. So one of the clinical limitations for drug-coated balloons, as Sensei Iida just showed you, is calcium. Calcium is where we live and breathe in the SFA. It's more common than it isn't. And so you have a myriad of devices that you can use. One of the trials that helped look at this, the trial that Tomas, myself, and Jim McKenzie led, was the definitive LE trial. And if you look to the left, which is the red circle here, this shows you the distinct differences between stenoses and occlusions on outcomes with directional atherectomy on a fairly long 6 to 11 centimeter metric in the SFA. If you looked at the SFA primarily, regardless of stenosis or occlusion, shown here, it was a 75% primary patency on an 8 centimeter metric. This was all driven by balloon angioplasty alone, had no drug-coated balloon at the time of this trial. So that's plain old directional atherectomy with adjunctive therapy, meaning balloon angioplasty in about 40% of the patients. Fast forward now about 18 months, and definitive AR, led by Tomas and Professor Tepe, looked at marrying drug-coated balloon with the directional atherectomy, so-called DART technique. So directional atherectomy and anti-restenosis therapy. Here, you had an 11 centimeter metric looking at the directional group with a comparator, a randomized trial. Remember, this was a pilot study, not meant to be a powerful, scientifically powerful study, but a thought-provoking study, looking at the directional versus, with combination therapy versus drug-coated balloon alone. 11 centimeter was the lesion length on this group. And if you looked at calcific disease, it was around 3 out of 4 had severe calcium or moderate to severe calcium. And then there was a subgroup, a very small group, about 19 patients that had severe calcium that were looked at individually for DART. This is one slide that gets passed over time and again when people talk about DART in the outcome of DEF-AR, which is critical to me, and I hope you understand why it's so different. This is angiographic follow-up. This is not sonographic follow-up. And it brings 3 points home to me. One is that if you did atherectomy and drug-coated balloon on everybody, there's no benefit to it. If you throw the kitchen sink at everybody, you'll get a fairly consistent outcome, but there's no benefit to the combination therapy. If you looked at the patients who came back and had long lesions, over 10 centimeters, there's a distinct difference between the directional group with drug-coated balloon versus drug-coated balloon alone. That's a 90% primary patency that's done by core lab adjudication, edge detection technology. That's a phenomenal number. And then in the place that you already know you fail more often than you succeed, look at the heavily calcified group, 60% versus a 40% metric. That, again, shows you benefit of the combination therapy. So there may be something to this idea of vessel prep here. And where you gained your bang for your buck in DEF-AR was, if you looked at the middle here, you gained the biggest part of your MLD with directional atherectomy as opposed to just plain old balloon angioplasty. So that was your biggest growth in that minimal luminal diameter. And then something that has not been borne out in reviewing DEF-LE is if you achieved a 30% or less residual on your atherectomy, it seemed to have an impact to the outcome. Again, it may be statistical hand-waving rather than being true science right now based on this, because the larger group did not bear that out in DEF-LE. What's ahead is now, the VIVA group is now doing reality. It's a marriage of those 2 groups. Long lesions and calcified lesions, they're marrying them together up to 25 centimeters, and we're going to see whether or not DART works compared with plain old balloon angioplasty. And so it's going to be multi-center, core lab adjudicated, all the bells and whistles. They have an IVUS sub-study as well as a histology sub-study, which are now closed. And so we're looking forward to the next big step. Jetstream is the only other device. It's a rotational device. This is the Jetstream registry. I just put it here because although the Jetstream registry was stopped, Nick Shamus and I are going to lead a Jetstream DCB trial for Boston, and so that's the next big step. So in Jetstream's registry, you can see that the crossover rate was huge for stenting as opposed to non-stenting, but the outcomes were fairly similar. So it'll be interesting to find out how this plays out. And then lastly, the only other big trial that's really looked at atherectomy when it comes to antirestenotic therapy, it's hidden in the data, is Liberty 360. Liberty 360 is a huge trial looking at claudicants and critical limb, and in the critical limb group, they broke out rest pain with Rutherford 5 versus Rutherford 6. Rutherford 6 played its own role as a group. And if you look here at the top, it's a kind of a busy group of slides because they group everything together, but this is the above-knee claudicant group treated in the majority of the patients in claudication. And I want to draw your attention over here. The vast majority, a la DEF-LE, were driven by angioplasty with plain old balloon angioplasty. There was a small group, under about 5%, if I can get the arrow back up, that were driven by DCB. They have not, at least I don't know of any subgroup analysis showing you the outcome of orbital atherectomy, which was the predominant atherectomy device for Liberty, with the DCB, but it would be very interesting to compare in a propensity matched evaluation of the DCB group versus the non-DCB group when it comes to Liberty. Apart from their male outcomes, which is basically the outcome for the driven for the critical limb groups, which is in red and green, the blue line shows you the benefit in the claudicant group. And the only group that they report, unfortunately, with Liberty on primary patency is the claudicant group. But very similar to DEF-LE, you have about an 83% primary patency in this group. Understand, of course, it was primarily driven by balloon angioplasty, not drug-coated balloon. But I do put it out there because I think it does play an important next segue when it comes to the combination or a marriage of the two. Tomas already talked about calcification, so I'm not going to talk too much about that. So how much is enough? Debulking is not the goal of therapy with many people who use atherectomy. For some of us it is. Rather, the issue is arterial compliance, and no one study has shown what metric, what's the aha moment for arterial compliance. In reality, I hope we'll be able to answer this question. And ultimately, as has been shown time and again with the overuse of atherectomy, it may lead to complications, whether it be embolic or aneurysmal dilatation of an artery that becomes critical to how your patients either progress or return because of failure. And so does vessel prep still matter? I think the SFA landscape is fluid. What we really do not know and have not looked at is head-to-head comparators. We as scientists have to push industry to do this. We're getting a little bit of headway there, but it's not a lot. Randomized trials really do compel a discussion on the treatment strategies when it comes to vessel prep. Calcium remains a principal disruptor. Whether or not reality answers this question or the disrupt trials answer this question is going to be up to their data set. And a leave nothing behind strategy appears to be the current trend for the SFA, though, again, no one group has really shown the benefit beyond the modest SFA lesion length. And importantly, how you fail in any of these. We've published our data on failure modes of the restenosis, and the directional atherectomy and antirestenotic therapy seems to have the best restenotic mode, which is more focal. So it may actually play a role not only in the index procedure, but how you work on it subsequently. Thank you for your attention.